This is a summary of the point of care for PoCUS 3-area ultrasound for deep venous thrombosis. The PoCUS 3-area scan for DVT should take no longer than 5 minutes. First, the patient is placed in a reverse Trendelenburg position with the legs slightly frog-legged. After the application of copious gel to the area to be scanned, the probe is placed transversely at the inguinal crease with the scanner's marker to the right and scanner in deep vein mode. If the patient is very obese, they may need to lie flat to allow access to the inguinal fold. You should see the femoral artery laterally and the common femoral vein medially. You should move the probe distally, 1 transducer width each step of the way. Here's what that looks like.
We're going to place the ultrasound transducer at the inguinal crease in a transverse view. When I do this, immediately below the transducer in the ultrasound image, I'm going to see 2 anechoic structures. The one that's going to be more medial is the common femoral vein. The one that's more lateral is the common femoral artery. The way I can landmark this is by looking for the junction with the saphenous vein, or the long saphenous vein. And we see this emptying into the anterior aspect of the common femoral vein. And in this image, we actually see the venous valves separating the long saphenous and common femoral veins.
Initially, you should just see the common femoral vein and the femoral artery as shown above. As you move down, the first additional vessel to appear will be the greater saphenous vein, just medial to the common femoral vein, which after the saphenous vein branches off, becomes the superficial femoral vein. Remember, it is a deep vein and not a superficial vein. Here's a scan of what that looks like.
We're going to place the ultrasound transducer at the inguinal crease in a transverse view. When I do this, immediately below the transducer in the ultrasound image, I'm going to see 2 anechoic structures. The one that's going to be more medial is the common femoral vein. The one that's more lateral is the common femoral artery. The way I can landmark this is by looking for the junction with the saphenous vein, or the long saphenous vein. And we see this emptying into the anterior aspect of the common femoral vein. And in this image, we actually see the venous valves separating the long saphenous and common femoral veins.
At this point, some operators like to rotate the transducer clockwise until they can get a longitudinal view of the greater saphenous vein running into the common femoral vein in this manner.
Evaluation of the most proximal segment of the greater saphenous vein, despite its identity as a superficial vein, is of considerable importance and does not add significant time to the examination. Presence of thrombosis in the proximal greater saphenous vein can lead to direct seeding of the common femoral vein and is typically treated as a DVT rather than a simple superficial venous thrombosis. One study noted that greater saphenous thrombi were the most likely to progress to proximal DVT. The operator in the accompanying clip is scanning the common femoral vein in short axis and identifies the proximal segment of the greater saphenous vein. The transducer is then rotated to capture a long axis view of the vessel. It can be clearly traced to its anastomosis with the common femoral vein. The operator returns to its origin, captures the greater saphenous vein in short axis, and proceeds to apply gentle pressure and documents complete collapsibility of the vessel lumen. The transducer is then moved 1 transducer width distally and transducer pressure is reapplied. This sequence of events is repeated along the proximal segment of the greater saphenous vein.
Make sure the saphenous compresses as well as the femoral vein. After a few centimeters, the greater saphenous vein dives deep and out of sight. This is followed shortly by first the appearance of the deep femoral artery or profunda femoris artery. It appears laterally. Then, after a centimeter or so, the profunda femoris vein also appears, as in this scan.
The point-of-care ultrasound DVT examination begins just proximal to the confluence of the greater saphenous vein with the common femoral vein in the inguinal area. The clinician should initially visualize relevant anatomy in a transverse view, which will enable accurate identification of structures of interest. The examination consists of compression of the vein to ensure complete coaptation of venous walls, followed by movement of the transducer distally by approximately the width of one transducer. Starting just distal to the inguinal crease, the femoral vasculature should be identified in a transverse plane. The transducer is then positioned just proximal to the greater saphenous vein and compression is performed. After confirming that the venous lumen has completely collapsed, the transducer pressure is released and the transducer is slid distally by one probe width, and transducer pressure is reapplied. The common femoral vein, deep femoral or profunda femoris vein, and the most proximal segment of the greater saphenous vein should be examined in this fashion. As the transducer is moved distally, the deep femoral vein will no longer be visualized after several centimeters, as it dives deeper into the femoral musculature. On average, approximately 4 to 5 centimeters of the thigh are scanned during the femoral segment of the point-of-care ultrasound DVT examination. As noted earlier, point-of-care ultrasound DVT examination shares similarities with proximal compression ultrasound examination. While proximal compression ultrasound scans the entire length of the femoral vein, the point-of-care ultrasound DVT exam involves scanning only the proximal segment of the femoral vein.
For a few centimeters, these four vessels, superficial femoral artery and vein, and the deep femoral artery and vein, can all be seen. Then the deep vein and artery disappear. At this point, you have completed the examination of 2 of the 3 areas of the 3-area PoCUS DVT procedure, and on average have scanned 4 to 5 centimeters. Many operators like to spend another minute following the superficial femoral vein down until it disappears into the adductor hiatus and courses behind the knee, but it is not required by the protocol. At this point, the transducer is moved to the proximal to mid areas of the popliteal fossa. Remember to keep the legs frog-legged, as straightening the legs can collapse the popliteal vein. If the patient is examined in the prone position, then pillows or towels need to be placed under the feet to slightly flex the knees because of this problem. Also, if the patient is very heavy, you may need to adjust the depth of the scan deeper to image the popliteal vein. Remember, in the popliteal fossa, the artery is deep to the vein. Thus, the vein will appear on top of the artery. Many operators use the mnemonic "pop on top" to remember this. Scan distally, transducer width by transducer width, compressing all the way until the popliteal vein trifurcates into first the lesser saphenous vein, which takes off medially. Then the anterior tibial vein comes off the popliteal and runs between the anterior tibial vein and what now has changed from the popliteal to the tibio-perineal trunk vein. Here's what that looks like. Free-floating emboli are only slightly more embologenic than attached thrombi, if at all. Baker's cysts are found in 85% of patients undergoing PoCUS ultrasound. Extreme obesity and tight-fitting clothes can lead to collapse of the inferior vena cava, which in turn can lead to difficulty compressing more distal veins, like the deep veins you are examining in the leg. The most common cause of a missed thrombus is mistaking superficial varices or collateral veins in the popliteal region for the popliteal vein. Remember, the vein should be immediately on top of the artery. A less common error is to mistake a lymph node for a thrombus in a vein. Here's what a lymph node looks like. If you scan up and down, you will note it is not in the lumen of a vessel. Turning the probe longitudinally can also help establish that it is not in a lumen. Here is what a thrombus in the proximal greater saphenous vein looks like. Even though it is a peripheral vein, because of the strong propensity of proximal saphenous thrombi to extend into the femoral vein, they are treated the same way a deep vein thrombosis is treated. This video shows a thrombus in the femoral artery. And finally, here's what a thrombus looks like in the popliteal vein.